The evening, it's wonderful.
Oh, now we've already started the recording.
Yes, 1 minute to go. I think 6:59.
Now we have to be careful
We'll
what we
start sharp at 7. Dr. Aruna, shall I start?
Exactly. 1 minute left. 1 minute left.
Okay.
मेरी वॉच सही होगी probably.
Yeah, perfect, perfect. Yes.
Yes, 7.
So, good evening, everyone. Once again, welcome you all to this very important webinar, the monthly webinar series of ISCCP, which is on 7th of every month for 70 minutes and at 7 p.m. So, we start sharp on time. So, today we are addressing a very important topic of the management of HPV positive tests as by the latest WHO guidelines. And Nana, it will be addressed by great stalwarts in this topic. Dr. Nirja, Dr. Premlata will be moderating the case discussion. We have Dr. Bhagya Lakshmi, we have Dr. Vijay Lakshmi. So everybody is a stalwart in itself for addressing this topic. So without any further delay, first and foremost, I would now hand it over to Dr. Aruna for giving the welcome address.
A very good evening to all of you, and thank you, Dr. Bindya. So it is very important topic which we are going to discuss, and Dr. Nirja is going to discuss this in detail along with the very important panel discussion. But before that, I would like to inform you that we, along with many members of the ISCCP, have attended the International Federation Society of Colposcopy Cervical Pathology Conference, IFCPC 2026, and France, Paris, and it was a successful conference where the Indian delegation was there. We have presented 6 papers, 3 lectures were given by myself and Dr. Sarita Sham Sundar. So we had a good representation, and what I felt there, that at an international level, we need to be more prominent. So from the next time onward, I would like to request you all, whosoever is interested, please communicate to us so that we can go there as a team. Because once we are having a burden of this disease, we need to have a very good representation at the international level so that we can be heard. And for this, I will need a help of all of you. So the next conference is in China, Beijing. I will request all of you to work from today onwards to present a paper, start collecting your data, and then we all will go together as a big delegation there to represent India. And representing India at an international level is such a thing that I cannot express the way I felt, and was the first time for me. Dr. Nirja must have represented so many times, but really it was a proud moment for me to represent India and represent ISCCP. So I would like that more and more people from the ISCCP family should come together, and we will try to have a representation in a good manner next time. So thank you all for your support and blessings. We have shared the our pictures, few of the pictures with you. Few we will load on the ISCCP website, our YouTube channel. So thank you all. So over to you, Dr. Bindya.
Thank you, Dr. Anna. And with this, I would like to tell them that there are a lot of ISCCP travel grants which people can avail if they are interested. So do apply next time in advance. So with this, now I will hand it over to Dr. Priyanka. Dr. V. Priyanka, she is the gynec oncologist at Vizag, and she's the convener of this meeting today. So over to you, Dr. Priyanka.
Thank you, ma'am. Good evening, everyone. And I'm sure next time we'll all represent at a in good numbers in China. Welcome everybody to this very important webinar on extended genotyping. And we have put in all our efforts to bring the best in this program. Before Is my screen visible?
Yes, it's visible.
Yes.
Dr. Priyanka, go to niche, PPT section, that PPT.
So our session would be basically in two parts. Initially, we'll have a talk by none other than Neerja ma'am, and then this will be followed by a panel discussion on our practical experiences in in other high risk or extended genotyping. It is my pleasure to introduce my teacher, Professor Bijal Patel. She's heading the Gynec Onco unit in Gujarat Cancer Research Institute, Ahmedabad, and ma'am has had privilege to train many students and an experience of more than 20 years. And Bhagyalakshmi ma'am does not need any introduction. Ma'am is from Acharya Harihara, Cuttack, and she is a chairperson oncology committee for OXY 2018 to 20, and she's currently the president of AOGI. Over to you, ma'am.
Thank you, Dr. Priyanka. It's my privilege to invite Professor Padma Shri Professor Dr. Nisha Bhatia, globally renowned gynecological oncologist, distinguished researcher, and key contributor to cervical cancer prevention initiatives. She was the first Indian to serve as president of International Federation of Gynecology and Obstetrics and led the 2018 revision of FIGO staging of cervical cancer. And she has significant contributions to peer-reviewed journals, particularly in gynec oncology and public health. She is at present president, AIMS Bhatinda. Today, she will share her expert insight on the evolving WHO recommendation for HPV testing and extended genotyping, a topic of growing importance in the journey towards cervical cancer elimination. We are honored to have her with us and look forward to an enlightening and thorough-provoking session. Over to you, madam.
Thank you very much. Thank you, Dr. Bijal, for that very warm introduction. Thank you, Dr. Aruna and Dr. Priyanka, for inviting me today, Dr. Bindia. It's a warm welcome from all of you, and I hope I will stand up to your expectations. And I will just share my screen. I hope you can see it.
Yes, ma'am.
Okay. So I thought I will just sort of start a little bit from before in this story of genotyping for the interest of some who may not have been ISCCP members from earlier. And just briefly to touch upon the cervical cancer and HPV epidemiology, how this guideline has been since 21, why HPV testing, what are the genotypes, what is the spectrum and implications, and what does this guideline say, how we can use it in our personalized clinics, how we can put it into screening programs. So this is the figures that we have from Globocan, which is compiled by WHO's International Agency for Research on Cancer, IARC. And it is done at regular, now 2-yearly intervals. I'm told the next one is going to be released. The Globocan 2022 is what we are using now. So 2024, I believe, will be released on 8th of July. And we'll see further what the new estimates are. But roughly 127,000 new cases and about 80,000 deaths is the sort of attributed to the Indian component. While it's the fourth most common cancer globally, it's still the second most common cancer for us. Globally, 77% of cases are linked to HPV 16 and 18. I just want to reiterate this slide, which I'm really pretty fond of, as conveying the point about removing the stigma for this infection. As common as we may say that our cancer data says, even much more common is the infection itself. It is estimated that average 85% of women and 91% of men will contract HPV infection at some point in their lives. So likely most of us have had it. It doesn't make its presence felt. We never know until we test for it. So there is not any reason to stigmatize the one who is found to be positive. Only 10% remain positive for more than a year. The stats vary widely depending on age and geographical region. One major problem we now face is the women in their 30s who come in contact with providers for treatment of infertility or STIs or routine screening. And the infertility ones are really the ones I feel very bad about, because their plans just get set aside from the IVF clinic. They come and they go to CIN treatment. And just to reiterate again, which has more implications in understanding a little about vaccines, which we are not really the topic of the day, but just to understand that there are a lot of HPV types, and they are tissue and species specific. What infects humans doesn't infect animals. What causes genital warts does not cause the plantar and palmar warts or the facial warts and all. So about 17 high-risk types that we have, which have some degree of oncogenicity, and presently there are 12 types which are mainly being considered carcinogenic in the IARC scheme of things. So as I said, globally, it's about 77% of cases by 16-18. But in India, it's higher, and it's about 84% of cancers which are caused by 16-18. So the first generation of vaccines really offers protection against the vast majority of cancers, because apart from the types which are caused, I don't know if you can see my pointer or not, so let me use this, which are covered by the 16-18, there are also extra types which have some degree of cross protection, and there are only a few which are benefited from the non-valent vaccine. In fact, the non-valent vaccine has more benefit in protecting you from getting an abnormal report from screening than it is from cancer. So really, that is the right type of vaccine for our public health system. What we are giving currently, Gardasil, tomorrow it will be a choice between Gardasil, Cervical, whatever, quadrivalent. Definitely non-valent may be better, but these are really pretty good. Now, I often hear from people that, I did the test and I got 52 positive, I got 82 positive, this 82 is not in the list and all that. So we must understand, if you look at this first column, which is normal cytology, and then we will see the low-grade, high-grade lesion and cancer. You see that they are pretty much aligned in terms of the proportion, almost like racehorses at the start of the race, even though 16 may be a bit more right from the start. And then you see, here you have in this one 16-18, but in the low-grade lesions, what data we have, which I are compiled, and many of us have contributed to this data, you see that there are other types which are still more common than 18 in the low-grade lesions. If you look at the high-grade lesions, you see that 18 has moved up to the second position. Others are looking more important than they were before. And finally, when you come to cancer, it's 16, 18, 45, third, and then these other ones coming. And some of these other players have moved down the line. So that is the reason why we constantly emphasize the 16, 18, and then 45, and especially in adenos, where these are the three main players all involved. So this is the chart which was put out by the WHO's IARC a year or two ago, maybe 24. And this is the one that has been picked up in the latest extended genotyping guidelines. And they now call them, as we were referring earlier, as high-risk HPV. Now it's being referred as carcinogenic HPV, CHPV, based on the attributable fraction of cancer, which you see in this last column. And HPV 16, which is way ahead in every respect, the percentage prevalence in people with invasive cancer, the percentage prevalence in people with normal cervical cytology, the odds ratio of developing cancer, and the percent attributable fraction. So it stands alone as what is called as now group 1A. Then you have 1B. These are the ones which are second in importance, still very important. 1845, their odds ratios are high, their percentage attributable fraction, especially 18. And then comes group 1C. These are the ones which are in the non-valent vaccine also. Up until here, the vaccination and done in good time is going to prevent all the way till here. 35, everybody thinks is a notable omission right now, because this type is actually more common in Africa. In fact, in our meta-analysis done many years ago, we found that it was more common in South India than in North India. So we would also like to see this incorporated probably in the next generation of vaccines when we get a decavalent. And then comes group 1D, which is 59, 39, 51, and 56. And they contribute, as you can see, a very small proportion, but nevertheless important. 66 and 68, which were considered to be in the carcinogenic, and most of the screening tests have 14 types. These have now been moved to group 2 and are not considered to be actionable in screening terms. So you are all familiar with this. You are familiar with the WHO call. The screening required of 70% of women with an effective test is currently an HPV test. Doesn't really specify more details in this as such, more than transition to HPV. And 35 and 45 being the optimum age from modeling perspective, when the infections that have been acquired at an early age, usually at the onset of sexual activity, highest in the third decade of life, and which have to be cleared by the immune system, would mostly be gone. Low-grade lesions that are going to revert would mostly be reverted. So 35 and then 45, 10 years later. And this is not new information. This has been known to us since 2006. Jack Cusick's meta-analysis of studies from Europe and North America, not from Africa or some disadvantaged situations. This is 55% sensitivity they found of detection of CIN2 and worse lesions by cytology. And in the same population, they found that the HPV was more than 95% sensitivity at the time they were using the hybrid capture test in all these studies. And as far back as 2005, WHO's IARC had endorsed the HPV testing, saying that it could be expected to be as good a primary screening method as conventional cytology. Time has proved it to be better. And the ALS trial again of 2005 showed that concurrent negative tests, because nobody wanted to stop doing PAP. We had such a PAP fixation. They can be reassured that their risk of unidentified CIN2 plus is approximately 1 in 1,000. So it's more than 20 years that we have known this, but it has taken us a lot of time to come here, mainly because of cost. This landmark study by Dr. Shankar in Barshi had a large number of women, 130,000 plus in 4 clusters, assigned to HPV testing, BI, cytology, and standard of care arm, which was to generate awareness and treat symptomatic women. They could show that a single round of HPV testing with hybrid capture would bring about a significant reduction in the numbers of advanced cervical cancers and deaths from cervical cancer. But given the constraints, they concluded, this was 2009, that 1 or 2 rounds of BI remains the present reality for rural India, and the development of affordable HPV tests may make that a reality in the future. What was even more reassuring from this study was the fact that if you were negative on HPV test, the chance that you would go on to develop a cancer was far lower than if you were negative on VIA. And that is the other big advantage of HPV testing. So high sensitivity and good negative predictive value. Again, you see, this is 2008, clearly shown that if you are negative on cytology, HPV, or co-testing at baseline, the risk of developing CIN3 plus over the next 5 to 6 years is there with cytology, but with HPV alone, it is just marginally more than with co-testing. And this was the basis for saying that you can have a 5-yearly screening interval rather than the 3-yearly of PAP. But you can see that even at 3 years, the PAP would miss a significant number. Again, the importance of 16 and 18 was clear from these studies, which showed that the ones who were HPV 16, 18 positive at baseline were far more likely to develop CIN3 plus over the next 10 years as compared to other high-risk types. And the HPV negative, because you will have some lesions, even in HPV negative, nothing is 100%, but very, very few. So in 2021, this WHO guideline for screening and treatment of cervical precancer lesions for cervical cancer prevention came out. And this showed you the options that you have if you do a screen and treat or a screen, triage, and treat. These 7 algorithms cover all possible scenarios of VIA, HPV, or cytology as the primary screening test. HPV could be self or clinician collected if it is HPV DNA test. mRNA is not for self-collection. And for the triage, anything from colposcopy directly to genotyping to VIA to cytology, all were there. And it was clear that for HIV positive populations, it is the screen, triage, and treat approach. And mind you that these all 7 algorithms are based on data. They all have data to support them. It's another matter that these data are mostly from research settings. And when you go out in the real world, as we have done with our VIA coming into our national screening program, the outcomes are affected by many, many barriers, lack of screening linkages, secondary, investigations and triage, the treatment facilities, the quality assurance. So you may not be able to replicate the standards that have been shown in the research studies. So this was very clear that people should try to transition to HPV testing, even if they don't stop using what they are doing. And if they're doing it well, even cytology has good sensitivity. But they should look at how they can transition to HPV testing. Whether you use the screen and treat approach or whether you use screen, triage, and treat approach, the nucleic acid amplification tests are the primary screening test. And those who are in the first approach go to treatment directly. In the second approach, there may be limited, or now we have extended genotyping also. VIA, colposcopy, cytology, dual stain cytology are all options for triage. Routine cervical screening is usually recommended at age 30. We must understand this also when we say universal screening. It means everyone, not a high-risk population, not a symptomatic population, but each and every person. And this is most cost-effective after 30 because that's the age when we see the cancers begin to increase. So you can start at 25, but 30 is where you must start. Affording persons in urban areas with the affordability, certainly we can start at 25. The priority age group when we go out for camps, etc., should be the 30 to 49-year-old women, where you get again the maximum rewards for the tests you do, as well as the maximum compliance with triage and treatment. But women over 50 to 65 who have never been screened, if you have the ability, please do it. And for HPV DNA testing, we are now quite comfortable saying every 5 to 10 years, not necessarily 5 years. The mRNA testing data is still at 5 years. In fact, there are some recommendations that for self-sampling, you should do it earlier, the repeat testing, because there is some level of accuracy that is less. So this is the guideline which now came out regarding the extended genotyping, and I feel privileged that I was a part of this group right from the inception of 2021. So this guideline has just been released last month, and it's a free download which you can get from the WHO website. So here there is a spectrum of tests ranging from no genotyping to full genotyping. No genotyping is what we have been widely using as hybrid capture. Aptima is also there. And you get an aggregated result which does not, it's actually 13 types that you get. And you don't really, but here, this was one moment to say that there are 13 types or 14 types, but here the WHO is just looking at the 12, are they there or not there? So these ones give you just all in a bunch. There could be one or more types, and you don't know which. But in the limited genotyping test, which we have as COBAS, for example, you can have 16 and 18 separately identified and the others in a pool. In Cepheid, you will also have 45 identified and the others in the pool. And in the extended genotype, this will clearly, of course, show 16 and 18, may include combined results with 45, and results for the other 10 types are usually pooled in 2 to 3 different groups. Individual results can be obtained by a full genotyping and may also include the non-carcinogenic types, but these are mostly for the research only, and you don't really need to do them in the normal population. So the clinical validation is important. Using a validated test is important because we must see the concept of the analytical and the clinical sensitivity. You know that all these tests which are doing PCR can take just a few viral copies and amplify them. And that does not mean that those very few copies would have resulted in disease. If we take the case of hybrid capture, for example, it was set at 5,000 copies viral load. Below that, it would show as negative. Above that, it would show as positive. Now we go with the Valgren criteria and the Meyer criteria, which are quite stringent, based on evaluating the test, not just with a few sets of positive, negative samples, but with samples which have been obtained from screening, which are divided as 1,000 specimens from there, 300 cytologically abnormal, 90 to 150 CIN2 plus cases. And the Meyer criteria are really very sensitive, very stringent. The sensitivity for CIN2 plus, the lower bound is more than 90% of the sensitivity of HC2, and specificity more than 98%, and even the inter and intra lab. So all of this is required and is there in these validated tests and is important because when you get reports from an open source PCR, you could go in both directions. You could actually amplify a few copies and show a result, which is not something which we should react to. Conversely, if they are not using sensitive enough primers, if the chemicals are lacking, you may find that you miss the cases which would be picked up by these tests. So, I don't know why this is jumping, I'm sorry. So the genotyping capabilities of various commonly available assays I have listed here as no typing, partial typing, extended typing, and full typing. So out of these, basically, COBAS is the one which is currently, QIAGEN has been the workhorse. It's got most trials and large trials have been based on this, the HC2. But now it's on its way out. The signal amplification test being replaced now. And COBAS is the one being used in most national programs worldwide. Cepheid has been a good sort of thing for a near, this is like a point of care test. And then it is also good because people already have the machine to do the gene expert for tuberculosis and can use the same one. BD on Clarity has been the first one to get the FDA approval for a home-based self-sampling. The COBAS has approval by the FDA for a self-sampling in a health facility. BD has now got it for being able to ship out their swabs to the patients to do it at home and send it back. Then you have Abbott's Alinity, which is there, which has got an extended genotyping. And currently the C-genes, Anyplex, Allplex are available for full typing in a validated format. So these provide specific actionable insights that differentiate and simplify the patient management, because you can see that if you have the limited genotyping, you would not really get to know the true risk of pre-cancer specifically due to one of those types, because it cannot monitor it beyond HPV 16-18 by virtue of the design. With the extended genotyping, you would be able to track the specific persistence, which is the most important determinant, the first determinant of the woman who needs to be followed up for developing cancer. So if we look at the 2021 guideline to the present guideline, what has really changed? What has changed is that this treat and triage and all that strategy has more shifted towards treatment, recognizing that women don't necessarily come back. We are in the process of developing a FOGSI position statement on HPV testing. And Dr. Bhaskar was of the opinion that in India, we really can't say that we have good follow-up even in our urban settings, because getting women back is not necessarily easy. So this suggests that if you are in a screen and treat mode, it doesn't really matter which genotype they are, treat them all, 1A, B, C, and D. But if you have a triage and treat approach, you can triage them with a visual inspection itself or a colposcopic impression, which are being preferred to the cytology and dual stain cytology. For the same reasons as cytology doesn't work well as a screening test, it has some lacunae as a triage tool also, although it comes with a very high specificity. And this is the additional layer that has been added on, is the follow-up capacity. And of course, they mean it in the context of national programs, but we can also look at it in the individual scenario. They say if you can follow up more than 60%, that's high follow-up capacity, less than 60% is low follow-up capacity. If you have the high follow-up capacity, it's good to do an extended or limited genotyping rather than treating all HPV positives or doing the triage with this PI or colposcopy or cytology. But if you have a low follow-up capacity, then treating is better than doing even a limited genotyping, and better than triaging all of them with these various options, because you lose people at every stage. I would say that especially, I think, when it's young women who desire to have their fertility, it's especially important not to have a one-size-fits-all. It's very important to them to have a personalized management so that you don't end up treating them unnecessarily. So this is now a bunch of 14 algorithms that are there. I will not go into the details of each of them because they are all available on this resource which I have mentioned, the genotyping booklet. And basically it decides on whether you are using no genotyping versus limited genotyping versus extended genotyping, and how you are going to triage them. So if you have extended genotyping, then the A, B, and C still go to the treatment. If ablative, that's better. If you are going to leap, you have to really think it through, especially, again, I will emphasize for the young women desiring fertility. In group 1D, you can triage with the colposcopic impression and manage according to the diagnosis. Now here, what you can do in all of these scenarios is to take a biopsy before you do a treatment and then do what is called a post hoc evaluation. Did it conform to your colposcopic finding? Did it not conform to your finding? And do you now need to do any more treatment or not? Over treatment, if done with ablation, is not something we worry about anyway. Now, the important thing also is that they suggest that you go ahead with the treatment based on the colposcopy diagnosis and do not need to wait for the histology confirmation. And so here you have the situation where you are going to do the extended genotyping. Extended genotyping, and you treat groups 1A, B, and C and triage the groups 1D with the VIA. So if it is VIA positive, you treat. If negative, you rescreen after 2 years. So please note this thing also, that the repeat testing is being recommended after 2 years. Now, in this respect also, Dr. Bhaskar was of the opinion, and I will be happy to see in the chat box your comments, all of you, that will your patient come back after 2 years, or will she be lost to follow-up? Recently, I was suggesting to someone to come for a routine screen after 10 years, and then I told her, please put it into your phone calendar, which you can take anywhere, and write down that in 36 you need an HPV test again. So will you be able to tell them to put it down for 2 years and they will show up, or you think we should do it 1 year just to be practical and keep in touch with the patient? That is the question. Now, I don't know why I have lost this. Yes. Now here is the option if you are going to triage with cytology, and here you will take the group 1D triage with cytology. If they are ascus or worse, you will do the colposcopy and manage. If they are not having cytology abnormalities, then again you will call after 2 years and see, and the positives will go to colposcopy. And then here is the situation of limited genotyping. So again, it will go in the same thing, the 16-18 treat, other triage with colposcopy. 16-18, please err on the side of treatment. You have seen, are at very high risk, and we should not lose them. We should err on the side of over-treatment in this group. And please note also that the negatives in all of these scenarios are being told to come for routine screening in 5 to 10 years' time. Here is the situation where you want to take the limited genotyping for triage with VIA. Here is the situation where you want to take for triage with cytology. It follows the exact same path. Now, here is the situation where you want to triage the group 1C. Here in this scenario, you treat only 1A, 1B. What is that? 16 and 18 and 45. These are the ones who go directly to treatment. And even in these, it would be desirable to have a colpo and biopsy in any case. The group 1C is triage with colposcopic impression and manage accordingly. Or triage with VIA and manage accordingly. And the group 1D go along with the negative to a routine HPV screening after 5 to 10 years. Really happy to hear in the chat how many people like this option and think it works in their settings. Then you have the women who are HPV positive with no genotyping, who you will triage with VIA. This is in a, suppose you have a camp setting, you have been able to set up the HPV testing. Recently, we had done the validation of the TrueNat HPV HR plus 8 types. Maybe you can do that. Maybe you can do Cepheid. You can get the result there and then, and you can do a VIA. In that case, you can take the positives, triage all with VIA. VIA positives can be treated. We are going to take only the women who are 30 plus. Many of them, even today, may have completed their families. Many of them may not. So we do have to keep that in mind when we decide what we are going to do. One important thing to remember is that the ones who are self-sampled cannot have the cytology triage. So now here is the ones who are no genotyping and you are going to do colposcopy and all. This is also a possibility even in camp settings now with portable colposcopes. You can do the colposcopy and decide, sorry, again it's jumping. And this is the one with cytology. So as I said, if you have taken a self-sample, you have taken that from the vagina, whether you have taken it or whether the woman has taken it herself. And so in this scenario, there is no role of a reflex cytology. Otherwise, if there's a situation where you have done the cervical sample collections, they come back positive, you don't have access to the woman, you can just ask the lab to do the cytology. And some of the systems are such that they offer you the reflex cytology of the positives built into the cost of the test. So then it is very simple. You will get the report back and the ascus or worse will go to colposcopy and management accordingly. The negative will go to rescreening after 2 years. If they are positive, they go to colposcopy. And this is the treatment algorithm. You determine the eligibility for ablative treatment by applying the acetic acid, and you know it already that if it is fully visualized, it is not going into the canal, it is not going onto the vagina, it is not occupying more than 2 quadrants. There is no associated history of postcoital bleeding or postmenopausal bleeding, which requires a more detailed evaluation. Then you can just take a biopsy and do the ablation. If they are not eligible for ablation, they can go to the LETs. LETs will definitely go to histology. If it is CIN3 or adenocarcinoma in C2, you just send them to treatment. And of course, if they have cancer, either because come on the LETs or you suspected it up front, you send those for evaluation, biopsy, management, etc. If there's a frank growth, it should be biopsied anyway. A frank growth should not undergo cytology or HPV testing or anything. These things can actually come back negative in women who have cancer, and you will be surprised that it can happen fairly often. So ablative therapy, of course, includes both the thermal ablation and the cryotherapy. Though more and more we are shifting to thermal ablation for other reasons. The cold knife conization is definitely possible if you don't have the LETs facility. And in these settings, it is being recommended that you do the post-treatment follow-up after 1 year and rescreening with an HPV test rather than BIA or cytology. Now, as I said, we are in an era of personalized healthcare. If you see the ASCCP guidelines, they have been saying already that you have to look at the risk, and they have really stratified it further into return in 1 year, return in 3 year, return in 5 year, and colposcopy recommended, expedited treatment or colposcopy acceptable, expedited treatment preferred, and all of that. And they have made their own algorithm, which definitely puts in cytology and dual strain as an option for triaging the middle risk patients and put the 56, 59, 66 into 1 year. So these are the old ones which were updated, but they have still kept 68. So I just put this in for your information. But coming back to all this extended genotype, the other option is that it will tell you very clearly what is the genotype specific persistence, because we know that persistent infection is the one. So is it the same type persisting or a different one? That you will know that it is the same type persisting only if you are able to do one of these tests. And it's important that it be validated so that we can trust it. And also when we have women who are going to be followed up later on by who have had vaccinations done in their adolescence, then definitely it will be beneficial to identify which genotypes they getting the infection with, because these other genotypes are going to become more common as compared to the ones which were contained in the vaccine which they took. So these have been integrated now into their charts in some systems in Denmark. They're doing this not in the programmatic way, but really in their own capital region. In Sweden, they are putting it into their national program so that they clearly indicate how it is to be done. And here it is done by the system which has been devised for home collection as well as sample collection by midwives. And it's a very elaborate one, but we can certainly consider how we can incorporate this in times to come as this becomes more common. So I will end by saying that we must transition to primary HPV testing and use a validated HPV test. In the new guidelines, we want to have colposcopy in treatment for the majority of patients. So colposcopy has become a very much required skill. We have to err on the side of treatment, especially ablation in cases who will be lost to follow-up. LEAP, in my opinion, should be done with care in women who are not requiring future fertility and should be very carefully assessed for the rest. Using the extended genotyping, you can discuss the risk and prognosis clearly. You can make the management more precise and accurate. And definitely this has greater benefits in the vaccinated women. So thank you very much for your patient hearing. And I'm sure we will attend the questions in due course as well. Thank
I
you.
think thank you very, very much for that so lucid and crisp presentation, I should say, because with the new so many things coming up, I think our audience must have really benefited from all the WHO new guidelines, but everything has been actually extended to in Indian context. Thank you so much, Dr. Nirja. But then I think Dr. Nirja is also heading a team which is actually going to formulate the new cervical cancer screening guidelines in India. So I think their HPV testing is again going to come up to our Indian guidelines. And I think in that, I think this extended genotyping and the risk score based treatment algorithms, all those things will come up. I don't know how much it will be, we'll be able to implement it, but I think it is going to come up in a short time from now under her leadership again. And the two important things which she actually marked in her talk is that from the initial which we had 14 high risk IARC, now we have changed to 12C. Carcinogenic is now represented as 12. We don't tell as high risk anymore. So it is carcinogenic. And then coming to the Valgent protocol and Mayer criteria, they may be a little challenging for us as of now. But I think this is in the era of precision medicine. We have to look up to it so that our results are perfectly fine. And then I think the whole audience has agreed to a 1-year follow-up. And I think treat screen positives is going to be the game changer in the coming years. And I think the most important, and again repeating your sentences, are no cytology for a growth. So please remember that we never do a cytology for a growth, because the cytology will only show you necrotic cells, and you may just leave the patient telling her that it's just an infection. So no cytology for a growth. Thank you so much, Dr. Nirja, for being so precise and crisp.
Thank you, Bhagya ma'am, for your expert summary on Nirja ma'am's talk. As always, ma'am has beautifully taken us through a very difficult and we go through this every day. If they are extended genotyping positive, then what are we supposed to do? So before we move on, we'll take a few questions. I think some of them have raised their hand.
So yes, there's a question from Dr. Shweta regarding the co-testing. So yes, we should leave aside the co-testing if we are doing a validated HPV test. But if you're not using one of these validated HPV tests, then you may have more faith from your cytology provider, and also you may get a better sort of reflection of the level of disease presence. So I would be reluctant to stop a good cytology service if I did not have a validated HPV test. I don't know. I hope that is clear.
Thank you, ma'am. Thank you.
So now Dr. Ajab Rao is saying that he has got a case with chronic cervicitis, PAP negative. So did you take a biopsy? A biopsy, even if you don't see any lesion, please take the blind biopsy, at least one from the anterior and one from the posterior lip at the squamocolumnar junction. If possible, even a 4-quadrant biopsy can be taken in absence of lesion. And if you take it with a nice Tischler forceps and it's sharp and good, and it's a very small biopsy, and the patient is also quite comfortable. If after that also you don't have anything, she has the ectopy, everything is normal, you can still do an ablation which will relieve her from symptoms of discharge and all those if she is having those, and will anyway do some good for this. If it is 18, it's also very important that we have done the endocervical inspection with a speculum and taken the endocervical curettage.
What is about fertility?
Age 25 year, I will not do. I should not have done her HPV.
Oh.
Thank you, ma'am. I think Dr. Priyanka, we should move towards the
we'll move on to
panel.
discussion.
Otherwise, we will be late. We are.
I'd like to invite Dr. Premlata ma'am to share her screen, and we'll take the comments from the experts in the end.
Yeah, once again. Am I audible?
Yes, ma'am.
Yeah. Good evening, everyone. Just give me a minute.
Premlata ma'am is from St. John's Medical College, and ma'am has had experience in HPV testing, and also ma'am is currently conducting a trial on HPV and in women with HIV. Over to you, ma'am.
Yeah. Is my screen visible?
Yes, ma'am. Please go ahead.
Okay. At the outset, very warm good evening to everyone. At the outset, I thank the organizers, especially Dr. Bindya, Dr. Aruna, Dr. Vamsi, and Dr. Priyanka for having given me this opportunity to discuss few of the cases of case related to extended genotype, what they said, case scenarios. But as far as you know that in India, switching over from a PAP test to a HPV test itself is a big task. And now switching over to extended genotyping, I think we need much more time to see the results. So what I will be discussing today is mainly on OHR in partial genotyping, and we can discuss the guidelines and see how we can go about with this. My screen is not moving. Yes. So we all have heard such a wonderful talk from Dr. Neeraja Bhatla, and there is no doubt that HPV testing is the gold standard. But at the same time, we know that since it's a very sensitive test, it generates such a high screen positive. And if we are going to treat all, screen and treat strategy, if we are going to apply, so it will be a considerable burden on the hospital. So we are looking into more options, how we can reduce this burden. And one such thing is the extended genotype, along with the other advantages as is already described, that it is going to be applicable to vaccinated population. It will help in improved surveillance. And of course, on a long term, this can even potentially reduce the healthcare cost. The fact that one needs to know about the carcinogenicity, which is all very well explained in a previous talk. So this is the basis of how we can go about. Without much delay, now I will take you through the case scenarios. All this is all covered by Dr. Neeraja. I'll skip it. So coming to our case one, I should tell you this is all about partial genotyping and not on extended genotyping. Case one, she is Mrs. X, 45 years, asymptomatic, never screened before, primary HPV screening with limited genotyping. So the screening which is available with us as a Kaya screen, this is a CE-IVD approved, not FDA approved. So, and it is a healthcare provider collected sample and OHR positive. So, Dr. Vamshi, so once
Yes, ma'am.
Other high risk positive, how do you want to go about now?
So, ma'am, we generally look at the type of test the patient comes with, whether it's an FDA approved or a not FDA approved. So, when we have patients with BD oncolarity, or which is the one where we, or any of the COBAS-based tests, we look into what we look into is that we try to triage them. So the triaging options which we have right now is either if it's called either a colposcopy directly or a dual staining is what we have been with the cytology we have been doing.
I think anybody else has anything to say?
Yeah.
Anybody has anything to say, Dr. Helen? So if colposcopy, cytology, all is a problem, it's in a very rural setup where
Yeah, we do
cytology
get.
is not available. Can you think of anything else?
No, we can do VIA because all the screening methods can interchangeably be used for triaging. So this is other high-risk positive. We can try and see if there's definitive lesion with VIA if there is no facility for colposcopy or cytology.
See, yeah. Yes, as we all know, the new guidelines also even for extended genotyping or partial genotyping, VIA triage, even before it was existing in the WHO guidelines, even the present guidelines still has got a VIA triage. But we have seen that when to do a triage, as Dr. Nirja has explained, when to triage, when to expedite the treatment is very clearly explained. Now, in our case, we have done a reflex cytology, and the cytology is a high-grade squamous intraepithelial lesion. So this is the image. Dr. Priyanka could just briefly, this is the image on normal saline and the green filter. How does it look? What is the transformation zone and how does it look?
Ma'am, this is a transformation zone type 1, and I don't see any, because the cytology is high grade, there is no growth per se, but in green filter also there is no abnormal vascularity.
And going to this is post-acetic acid application.
There is an aceto-white area at 7 o'clock.
Yeah, it may be a little difficult.
Probably it is in the endocervical region, so near the ectropion.
Usually,
yeah,
it is like a diffuse aceto-whitening around the squamocolumnar junction. More in the columnar epithelium, you can see the mottled white appearance. More so at 7 o'clock. And anteriorly, you can see that patchy areas. It could be a glandular lesion.
No, if you can see, for me, very
endocervical dense aceto-white areas.
Your squamocolumnar junction is somewhere inside, and these are all, this whole thing looks like a transformation zone. If you can see, this whole thing is a transformation. The squamocolumnar junction is almost at the ectocervix here. Okay. So the biopsy here, as we have taken, we have not taken a biopsy. We have directly gone for expedited treatment here because it is HSIL and OHR with the HSIL directly. We have done an expedited treatment, and this showed to be a multifocal high-grade squamous intraepithelial lesion, that SIM3 lesion. So what I wanted to just highlight here is that even in OHR, you can see widespread lesions, though the attributable risk is less, there can be a widespread lesion in OHR. Similarly, this is another case of OHR with reflex cytology showing high HSIL. If you can see here, it's quite a large lesion, high-grade aceto-white area occupying almost circumorally throughout the entire cervix. Similarly, okay. Anything else to say? Yeah. Similarly, this was another high grade, but the aceto-white picture is not there. But this turned out to be OHR with microinvasive cancer. You can see such wide, extensive lesions in these OHR groups. We have n number of cases with OHR because in our population, the maximum number of positivities are OHR rather than 16 and 18. Quite widespread lesions are seen. So coming to this, it's already explained what is the attributable fraction of cancer with these OHR groups?
Can I answer that, ma'am?
Yeah, please go ahead.
So coming to the other high-risk genotype variants, so 16 generally contributes to around 60% of the total cervical cancer load, and HPV 18 around 15%, leaving apart if we see combine the HPV 45 and the group 1C of the oncogenic potential HPVs, the risk attributed to the cervical cancer occurrence is around 28%. So in the very low oncogenic potential, which are like the 59, 39, and 51, they are attributable to less than 2% of the cervical cancers.
My cursor, this is not moving anything. So this is one of our another study where we did distribution of high-risk HPV types. If you can see here, the OHR group is the highest. It is around, wrongly written here, it is around 71% is the OHR group. And in fact, we have screened a high-risk population like commercial sex workers, and the positivity was almost to the tune of 34%, with the highest being the OHR group. So coming to the newer recommendations, what are the newer recommendations when with this OHR, other than 1618 OHR, when partial genotyping is performed or when extended genotyping is performed? Dr. Gitanjali, will you be able to explain this?
Yeah. The new recommendation as such, what we practice usually is when partial genotyping, 16 and 18, they are high risk group, potential carcinogenic genesis. So you subject them for the colposcopy. The other high risk group, usually we, depending on the situation, if the reflex cytology can be done, it can be done. Otherwise, VIA or colposcopy can be recommended.
Yeah.
Can I add?
Yeah, please go ahead.
Ma'am, because I did say that point, and Madam Nirja has also shown very nicely in her slides also. No? So this American Society of ASCCP, they had done this triaging, na? And like it really sounds very nice if we can follow through, I feel, because it would make for your uniformity in study also. So like Madam had said, 16, 18, we should go for immediate colposcopy. So this is sort of a risk stratification where other high risk are there. We triage with cytology or even dwell staining. I know we don't do that. We don't have that facility here, but that option was being mentioned. So I just wanted to say that. And of course, for 56, 59, and 66 cytology, I think recommendation was to repeat or wait it out. Thank you.
So
I want to add
Dr.
something to it.
Yeah, please, Dr.
So the WHO says that you have to stratify what type of patients you are dealing with. So if it is a low follow-up or a high follow-up, so if it is more than 60% follow-up at each step, then you can go for a proper triaging. But if it is less than 60%, then you need to go for a treatment straightforward in these cases wherever you are doing this limited genotyping. And moreover, 1A, 1B, 1C, which includes the other high risk type except the 4 types last ones. So in those cases, one should go for a treatment as such. And triaging can be done wherever possible if you are having an individual clinic. But if you are setting up as per WHO, if you are setting up a setting where you are doing a mass screening, in those cases, you can go for a triaging with a VIA or colposcopy preferably. Cytology, they say ki it's not preferable over the VIA or the colposcopy. Here you have said in first 3 cases that HSIL comes. So whenever HSIL come, we must go for a straightforward. Then there is no sense of going for extended genotyping or anything else. We must go for a colposcopy and biopsy in those cases without any doubt, because HSIL, you cannot leave them as such.
Yes.
Thank you.
Dr. Premlata, can I add?
Yeah, please, Vamshi.
Ma'am, since this is again a clinical discussion on case to case, and we might sometimes differ from what the guidelines say, and even Dr. Neerja ma'am might also approve. So we have a very good follow-up and a support system at our center. So whenever we get any OHR or even a high-risk positive, we try to keep, because colposcopy and dual staining, we try to do at the same sitting. And if nothing is visible and if the what you call the dual stain is also negative, we have tend to keep them on follow-up. So we haven't not been doing biopsies, and our results were quite okay. So I don't know in this era of de-escalation how this will be taken. So why WHO has never still mentioned that in a good resource setting and a good follow-up setting, even observation is an option even in a high oncogenic viruses, because most of them tend to clear up by 1 year.
No, I mean, most of these screenings are done about the age group which we are screening now. It is all around 35 to 45 years. Of course, when you are screening at a younger age at 25 starting, yes. But I think for an Indian scenario where we start screening at 35 and 45, whatever they say observation, they would have already married for almost 15 years, 20 years. So I doubt that there is going to be a clearance after those many years, though it may be the first occurrence.
But
Yeah,
when the patient has come with a first screening test as other high-risk positive, we have to triage and confirm that there is nothing, either colposcopy or cytology. Then we can keep her under follow-up if there is.
See, there is the role of the extended genotyping, and nowadays extended genotyping is available. So if you can go for extended genotyping.
No, ma'am. I
And
was
1A,
referring.
1B, 1C, of course, we need to go for a treatment, and 1D, you can have a follow-up. And then, of course, you need to individualize the patient if she is coming at the age of 45 years or she is coming for at a 25 years, as Dr. Premlata said, that we need to see those things also. At what age is she coming?
Ma'am, I have a question. If a patient, we usually do COBAS in COBAS platform where they give only 16 and 18 and the others are other high risk. Is there any role of repeating if it is reported as OHR, and then is there any role of repeating extended genotyping test in such patient to know to classify them into 1A, 1B or 1C, 1B, 1B, 1C, 1D, because 45 is not reported in them.
I think rather than it is better to go for a VIA or a colposcopy screening rather than spend once again for an extended genotyping is what I feel, because ultimately we are all doing to see whether we need to do a colposcopy and treat her or to keep under follow-up. So once we know, it is better to do a VIA or a colposcopy than to switch to another extended genotyping once you have already done a partial genotyping.
plus generating our Indian data is a very topmost priority, I think, out here.
So, and it is also very, very important, as already mentioned earlier, that using the right test of assay is also very, very important. Otherwise, you may come up with false positives or false negatives. So I think this question I would like to ask Dr. Vijayalakshmi here. So what are the recommended assays for primary HPV testing, and what are the recommended approved assays for extended genotyping?
Thank you, Premlata ma'am, for this question. So I think that one of the best assays that we are having for extended genotyping is C-genes allplex. So this particular assay works on the Biorad qPCR machine. So we have generated some real world data on this platform. So what we did is we did a community-based screening on COBAS using the partial genotyping. And when I presented this data in one of the international conferences, Dr. Neerja madam gave me a very valuable suggestion to look at what the OHR types are in South India. So I took her, advice, and then we started doing the extended genotyping to understand what OHR types are there. And we've got some very interesting results, which I even presented in the IARC 60 conference, which happened in Paris recently. So we are getting a lot of non-16-18 types, madam, which we have been able to identify in the HCIL, LCIL, and in the ASCUS cases. So looking at the HCIL cases, the non-16-18 types that we are getting in South India is HPV 33, 51, and 35. So if you see, HPV 35 is not covered in the vaccine. So HPV 35 is definitely coming up in the South Indian population. So therefore, if you look at all the other types, I think the C genes assay is validated as well, and which is doable. So if anybody wants to do extended genotyping, I would suggest you can do with the C gene. It works well.
But what
Is
about
this
the
FDA approved?
Yes, ma'am. It is FDA approved, madam. So
Okay.
they have now come up with an automated, the extended genotyping can be done on an automated platform also. So just like, a Hamilton thing has been coming up with the CGene platform also, but it is not coming in India. Nobody is using it, the automated one, but it works very well on a qPCR based setup. So especially if for a follow-up case, if you want to understand if they are clearing up a certain HPV, many of the women will be having multiple HPVs, madam. So we have more than 1 or 2 genotypes in these women. So you to understand how during their follow-up, we normally do the extended genotyping to understand if the same genotype is persisting or any other new genotype is what they have got. So we are routinely doing the extended genotyping.
Okay. This I have just taken from the WHO guidelines only. What they have suggested is COBA for limited genotyping, COBAS, then ABORT real time, then OncoPredict real quality. As far as extended genotyping, this is something which I don't know. Expert HPV.
No, ma'am. Expert
It
HPV is
mentioned-
Cepheid, madam. So there is a new publication which has come. The CGene assay is definitely validated, madam. It is a Korean company.
Okay.
SEEGENE. So this particular assay works on the Biorad machine. So you need to have a Biorad platform, and the assay will work out to around 800 rupees, madam.
Okay, fine, thank you.
Ma'am, your take on TrueNat XR, the latest one which is approved by the Indian agencies?
Sir, we are validating that platform, sir. So far, the results have been quite encouraging. So once we validate it, I will be publishing that, sir.
Okay,
We're
we
working
have
on
that also.
Yeah. TrueNat, we are validating that with comparing it with COBAS and also with the Alinity.
Okay. So moving on to our second case. So Mrs. X, 45 years. Once again, primary HPV testing. It is multiple HPV types, positive 16, 18, and OHR. But surprisingly, the cytology was NILM. Okay, but the image, I'm sorry, I couldn't put the image, but I can just describe. The image showed that it was supposed to be only positive for some low-grade lesions, which is occupying 3 to 4 quadrants. The biopsy is still awaited. So what I want to know is, what are the options, management recommendations when multiple HPV genotypes are positive? And once again, I think Shravanti, can you just take up the case?
Yes, ma'am. So if we have done an extended kind of genotyping in this kind of patient, we would have had more risk stratification. And if there are multiple positive HPV genotypes, we should definitely take the highest risk category as the primary base to plan our next step of management. So if there is a HPV, for example, if somebody has a HPV 45 and also the lower risk 1D category kind of HPVs, then we should definitely take it as like the prioritize the HPV 45 infection and do the next step of management based on that guideline. So despite the cytology being negative in this case, if there is no extended genotyping, but because it is other high risk HPV types, we should definitely go for colposcopic examination if that is available.
Yeah, I think we are supposed to treat with the highest risk, as already said. And is there any evidence for synergy between when there are multiple high risk groups?
No, generally, no, it is not. Cervical cancer is generally a monoclonal disease. So multiple infections might be present, but it is not that it will add on to the risk of developing a cancer with HPV, multiple HPV type of infections.
Oh, thank you. Then moving on to a third case, she is Mrs. X, 38 years. Once again, primary HPV screening was OHR positive and reflect cytology was normal. This was last year. So we repeated the test after 1 year. Definitely, we didn't do anything. We just followed her up, repeated the HPV testing after 1 year. It is still persisting OHR, so we don't know whether there was type shift, because this is a disadvantage when we don't know the extended genotype. It is once again OHR, and the reflex cytology is LC. So what next?
Go for colposcopy if it can be done.
Okay. So
She has had persistent.
VIA is also an option, yeah.
So suppose here, if it is OHR positive and once again NILM, would you have gone for a colposcopy?
Yes.
Yeah, it's a persistent.
Persistent infection.
Yeah, once there is a persistent infection, colposcopy has to be done. So this was the colpo image. We could see here some low-grade lesions, and of course, we have done a thermal ablation for this lesion. So what I want to know, the few other questions is, when sometimes they refuse to come once again, can self-swab be done for surveillance? And if yes, what? And if no, yes. Can you do a self-swab when you do a surveillance?
Yes, ma'am. I think self-sampling is approved. It can be done.
Self-sampling, I
once
would like
positive-
to add, self-sampling can be done, but for the self-sampling also the platform should be used that is the approved one, not the all test can be done on a self-sampling. That is very important to understand.
Oh, but preferably, probably it will be better, because self-sampling we cannot know the cytology. So maybe it is better to go for
provide a
collection sample, because you can do a reflex cytology in the same thing. Okay. So these are the approved screening test. As already said, only BD on Clarity has for home kit collection. Others are still in the in-clinic self-collection swab. This teal band, that also has approved home collection. We also have our study of 1,500 women we have done with the self-collection. But of course assisted. It was home collection, but of course clinician has assisted when there was a difficulty. And our positivity rate was quite high in the initial thing, but towards the end, because since these were all women in sex work, because they have collected in between their maybe profession, and we had towards the end lot of false insufficient samples because of the gel and other things being used. This was what our experience in those 1,500 cases. Around 200 cases we got insufficient sample. So with this, I think I will conclude the panel discussions, and I would like our chairpersons to give a concluding remarks.
So thank you, Dr. Premlata. It was a wonderful case discussion on various HR, HPV types, high-risk extended genotyping, which the guidelines have come. And we need to understand, whenever at an individual level, we are ordering the HPV DNA testing, from which company, which lab test they are being used. It's not that somebody from Lal Pathology is coming to you, or when Bexy is coming to you, you need to say what approved test kit, because whatever guidelines have come, they have said clearly mentioned that these are for the approved FDA validated test. For this, Dr. Nirja has very nicely explained that those should have been approved by using the Mayer's and the Valgen criteria. So that is very important to understand. There are so many. If you see one of the papers in 2023 published in a very good Lancet journal, that there are around 300 HPV DNA tests available. And out of that, only 20 are validated, and only 25% of the total 300 tests have performed some of the studies which were validated. So this is very important. To any HPV DNA testing, any company coming to you, you cannot use that. And you need to understand in what way that extended genotyping or limited genotyping, which Dr. Nirja has nicely explained, that they are using what platform. See, if they say, I'm giving you a 20 test, I'm giving you 20 viruses for the same. So there is no benefit of it. that if you are doing as such, none of the guidelines are there for the full genotyping. Although enduring guidelines have been come in the last 2025 by IASCCP, which clearly says regarding the higher risk type to be taken. But still, you need to understand that at a practice level, which most of the ISCCP members who are attending are a private practitioner, they understand two things very importantly. One is what typing is being given by that company, that is a limited or extended genotyping. And second, what tests they are performing, that whether they are using BD oncolarity or alinity or a CPET, what test is being platform has been used, because we need to see the validated platform that has to be taken by all of us. So thank you all, Dr. Premlata. It was a very
I have
nice.
2 questions for you.
किसने पूछा? अरे मैम,
Aruna.
हाँ
Yeah.
हाँ मैम.
Yes.
Okay, ma'am.
So we are talking a lot about validation. So if we are so strict about validation, so when it comes to implementation, since India is such a vast country, would we be able to cater to all? Because I keep on all the people who come to me about HPV testing, I ask them about validation. So half of them are actually not able to answer what is the platform they are using.
Yes,
So
that
only
is
thing
the
is
problem.
that PCR, madam, we are using PCR. So, yeah.
I want to give you a very good example for that, ma'am. So the Valent criteria, Algent criteria, and the Mayer criteria is like, one is the platform used and other is the passing criteria. So NEET, BNB वाले organize कर रहे हैं और 75% passing marks हैं. Now the tests are there to compare which test is best. But minimum criteria has to be fulfilled. मैंने आज 100 टेस्ट करके कह दिया मेरा वैलिडेटेड है, दूसरे ने 1000 कर दिया, दे सेड दे वैलिडेटेड, वी कांट टेक, वी आर यूजिंग आवर पेशेंट्स आर नॉट गिनी पिग्स. So validated kits, India, madam, has nicely, we have taken out the TrueNet, which will be very cost effective, and they are into the process. We will use a validated test. Till then, every company we cannot cater on ki nahi. It's this is the thing which we need to give respond to our all the members, that we need to see this.
Yeah, we are using Roche primers.
Yeah, Roche. So Roche is approved. Roche is approved.
So one thing that people who are having validated platforms can help validate Indian kits, madam.
Yes, ma'am.
That is something we are doing in our laboratory, where from our laboratory we have validated several Indian kits.
Yes, ma'am.
And
So
many of them don't perform. I don't want to mention the name. Some of them don't perform at all. There are very few kits which are able to perform, and that too for certain genotypes they miserably fail. Especially COBA's platform is very good in picking up HPV-18. No other platform picks up HPV-18 the way COBA's picks up. So sometimes when we compare results between COBA's versus Alinity versus C-gene, you see that even many of the HPV-18s are missed by C-gene but picked up by COBA's. So therefore, these differences are there. But it is at least it is helping us to decide to go for the validated kits, like how Aruna madam said. It is important to go only with validated kits, otherwise the whole effort will go waste, ma'am.
Yes, we need to have a criteria, some criteria of passing. We cannot use just like that. And we have a potential to do that. We have come, Serum Institute has come with the Sarvavec now. So finally we are, so why not? Why not we can have it? So we should be, a good research work should be there and it should be validated.
And
it's already feasible for a country like ours.
Yes,
definitely.
60% follow-up rate. That Aruna, you told me, WHO has come up with the guideline that there should be at least 60%. So how do we actually find out which is 60% or less than 60% follow-up?
And one more add up to that question, that 60% follow-up, are we referring for only those who tested positive and we are calling them back, or for even those who we have recommended for routine screening?
You muted or
okay. So there is a question on a 60% follow-up. So whenever we are talking of the 60% follow-up, that is at every level. That patient will come after your counseling, that is 60%, then she will come with the report 60%, then she will come for a colposcopy 60% and treatment. This is.
Now, do we have any objective method of doing it, or it's just abstract?
No. See, that is the thing, ma'am, that is used at a mass screening level.
Okay.
If individual, I am sitting in my
Understand.
clinic,
Yes, yes,
I'm
yes.
I'm clinic. If my patient is good, she is going to come tomorrow or day after tomorrow. As per
No, no,
advice,
no.
it is good.
Understood.
That
Yeah.
has to be individualized. We are
So
not
we
doing
need
a
to
mass
have data on
screening.
that also.
Yes.
What is our follow-up rate, and then
What is follow-up? So we understand that which patient will come, which patient will not come at an individual level. That is why they said, ki if you have any doubt, go for a treatment of all HPV positives.
Maybe practically that is a follow-up is a not 1 year, it is for 20-25 years follow-up. Maybe they may come the first year, second year, but on a long term, we don't know how whether they do come for a follow-up. So it is better
Exactly.
to check.
Because in my setup, even for malignancy, diagnosed malignancy, treated under remission, and then lost to follow-up, I encounter cases like that over the last 7 years that I've done
same here.
cases.
Same here. Helen, India is not
Great.
different in many things. So 2 chemos and lost to follow-up and come back after 6 months
And
with again
I would
status.
like to tell you here, I went to IFCPC. There was no talking of this genotyping there. Whole of they have not talked of the WHO. This is guidelines. None of the lecture was there.
So what was their gist of IFCPC?
They
Was
were
it different
generally
from
talking of CIN2, TZ3, AI based, all those things were there, but they did not talk an HPV vaccination. But they did
screening?
not
What
talk
is the screening? What method do they recommend?
very less topics were there on that. They told that HPV screening, but there was not much
Yeah,
a
because
talk
it
on
was
it.
only on cervical pathology, no? And
Actually, Aruna
colposcopy.
madam, I was there the previous week in Paris presenting our data in the IRC 60. I didn't realize if they would have given me little more leave, I could have presented the same data in the IFCPC, which was happening just a few days later in Paris, the same place. So probably I
That
missed
would
this
have been
meeting,
very
but here
nice. Yeah.
afterwards, as you pointed out, we all need to go as a team and present, ma'am.
Dr. Vijay Lakshmi, you should become a member of ISCCP.
I'm already a member, ma'am.
You are become okay.
Because when the
Then
meeting
you will
happened
get
in
all the
Chennai, I became a
informations.
member. Yeah.
Neerja ma'am wants to say something.
Neerja ma'am, final.
Them is muted.
Ma'am,
IFCPC that they froze the program, you know that very well, some 9-10 months ago.
Yes, ma'am.
It's so strange to freeze a program when we just start thinking.
Yeah.
So I think that is one important reason why they don't have it. And the second thing is that whether it be IFCPC or whether it be ASCCP, they don't give importance to WHO guidelines. They are all fixated on their own things over there, and things are very different in their setups from what we experience in the lower middle income countries. And even for us, it is not at all mandatory to follow the WHO guidelines. Every country decides how they will do it. So, like, we are probably now deciding that we will not do 2 yearly follow-up kind of thing, you know. So just to say that this IFCPC conference, their whole their whole design is very different, and only they will come up with some decent development probably or something. And the French anyway have their own way of thinking, and you can't break those barriers.
Definitely, ma'am. So I think Dr. Priyanka
Yes,
or
ma'am.
Dr.
Thank you very much. We had a very insightful and wonderful evening.
Galaxy S26 has raised hand, wants to speak something. Don't know who is.
बहुत देर से उठा हुआ है मैम.
हाँ, बहुत देर से है
It
मैम
is
वो.
raised since the beginning of the
Since the
session.
beginning.
अच्छा, I didn't realize. Okay, please go ahead.
So, madam, carcinoma HPV is reliable?
Carcinoma is
Cobas
performed
based.
in Cobas platform. So
Yeah, it is
based.
reliable. It is done on Cobas 6800.
And what about this Gaia screen? Is it CIVD approved? So for primary HPV screening, is it applicable? Gaia screen, Dr. Vijay Lakshmi.
Yes, ma'am. It is, I think, WHO pre-qualified. If it is not FDA approved, you can use WHO pre-qualified assays.
What is that? Gaia?
Gaia screen, madam. Kayajan ka.
Kayajan
Kaya screen.
Okay. Yeah, Dr. Nisha.
No, mine also. Hold on. It's not going down automatically.
So I think that's all for the day. On behalf of ISCCP, myself, Dr. Nidhi Gupta, wants to convey a great thanks to Dr. Priyanka, who has organized this webinar on a recent topic and collecting all the stalwarts related to that recent topic on the platform. I thank Dr. Nirja ma'am for such an enlightening lecture and Dr. Premlatha ma'am for such an interactive and informative panel. Thank you so much.
Thank you.
Thank you, everyone.
Thank you.
everyone.
Thank you, ma'am.
Thank you,
Thank you,
everyone.
Thank
everyone.
you.
Thank you,
Thank
Dr.
you.
Poorna.
Thank you. Good night.
Good night.
Thank you, ma'am. Good night, ma'am. Thank you so much.